Welcome. This presentation introduces the 5-domain model as a practical way to organize trauma treatment decisions within em-dir therapy. The central claim is modest but useful. People with the same diagnosis and even similar target memories may need very different next steps today. The model gives us 5 areas to check: crisis stabilization, education and understanding, skill development, social connection, and meaning and memory work. This is not a replacement for the adaptive information processing model, em-dir 8 phases, or protocol-specific decision-making. The 5 domains describe areas of current need. The 8 phases describe the clinical workflow through which em-dir therapy is conducted. They answer different questions. Over the next 38 minutes, we will define the model, map it onto em-dir practice, and apply it to one composite case. I will leave approximately 7 minutes for discussion. Em-dir clinicians already know that diagnosis alone does not determine treatment. 2 clients may both meet criteria for PTSD and differ substantially in current safety, dissociation, sleep, relationships, substance use, medical burden, shame, cultural context, and capacity to recover after a difficult session. The same person can also present differently from week to week. A client who could approach a target last month may arrive after a housing crisis, a medical setback, or a relational rupture with much less available bandwidth. The 5-domain model makes that variability visible. Instead of asking only, what target are we processing? It adds, what is most urgent, what is limiting the work, what strengths are available, and what would make the next step more workable. This is particularly relevant when therapists feel caught between 2 unhelpful extremes: processing as quickly as possible or delaying indefinitely in the name of preparation. A domain formulation supports a more specific, revisable decision. Consider this composite case. The client has completed several months of treatment. They understand the PTSD diagnosis and can use grounding when mildly activated. They sleep about 4 hours a night, remain in an emotionally coercive relationship, avoid most friends, and want to process an assault immediately because they believe that real em-dir means getting to the memory. Take 30 seconds and choose where you would begin. You might prioritize safety planning, sleep, relational options, additional preparation, target assessment, or carefully dosed processing. Also notice what information you would want before deciding. There is not one answer hidden behind the slide. The exercise is meant to expose the clinical variables each of us privileges. A flexible model helps us discuss those variables without pretending that one domain must always be completed before another begins. The map contains 5 domains. Crisis stabilization addresses immediate safety, acute risk, basic functioning, and enough steadiness to choose the next step. Education and understanding addresses whether the client and therapist have a coherent, usable explanation of symptoms, triggers, treatment, and the logic of protective responses. Skill development addresses regulation, orientation, boundaries, communication, daily functioning, and other capacities that create options. Social connection addresses co-regulation, attachment, trust, belonging, relational safety, community, and the therapeutic relationship. Meaning and memory work addresses trauma targets, maladaptively stored learning, identity, grief, moral injury, narrative, purpose, and integration. The domains overlap. An intervention may serve more than one domain, and progress in one area may expand options elsewhere. The model is less interested in assigning techniques to boxes than in clarifying the current clinical intention. This distinction is essential. The 5-domain model is not a stage model. A stage model implies that the client completes one level and earns access to the next. That can unintentionally turn stabilization or preparation into a readiness test. It may also imply that returning to practical safety or skill work represents regression. In this model, the therapist can work in several domains during the same session. Psychoeducation may reduce shame while a grounding intervention supports orientation and a therapeutic relationship provides co-regulation. Memory processing may proceed while the therapist continues to monitor safety, consent, and recovery capacity. The direction can change when new information appears. A return to crisis stabilization after a medical diagnosis, relational rupture, or suicidal escalation is not moving backward. It is treatment responding to the current profile. The map should expand clinical curiosity. It should never become another checklist that clients must pass. A domain profile is a snapshot, not a permanent trait. The profile changes with the target, current stress load, medical status, developmental context, relationships, substance use, sleep, and the support available after the session. It also changes as treatment works. This means readiness should be described specifically. Instead of saying, the client is not ready for em-dir, we can ask, not ready for which target, which procedure, at what dose, under what conditions, and with what recovery plan. That language improves both precision and hope. A client may not have enough capacity for sustained standard processing of one target, but may be able to complete assessment, strengthen orientation, use em-dir, work with a restricted target, use CIPOS informed distancing, or choose another domain entirely. The formulation remains provisional. We select an intention, observe the response, and revise the map rather than defending the original plan. Crisis stabilization is broader than emergency management, but it includes emergency management when needed. We assess immediate danger, suicidality, violence risk, intoxication or withdrawal, severe sleep loss, medical instability, inability to meet basic needs, and whether the client can use available supports. We also consider coercive control, housing instability, and other environmental conditions that cannot be regulated away. The goal is not perfect calm. Trauma treatment would become inaccessible if clients had to be symptom-free before meaningful work. A client can tolerate activation in the office and still be poorly positioned for the planned work. Signals that crisis stabilization needs attention include escalating self-harm risk, severe reduction in sleep, inability to eat or take medication reliably, dangerous substance use, marked disorganization, active violence, coercive control, or a level of activation that does not settle after sessions. We should also examine the recovery environment. Who will be present afterward? Does the client have to drive a long distance, return to a dangerous home, care for children immediately, work an overnight shift, or manage a medical condition? This is not an argument for avoiding processing whenever life is difficult. It is an argument for matching the target and dose to the whole context. A narrow target, shorter sets, more frequent orientation, or a different procedural choice may be appropriate. At other times, the safest treatment decision is to address the surrounding crisis first. For em-dir therapists, safety before death means making the intervention specific. Readiness is a relationship among the person, target, procedure, dose, context, therapeutic relationship, and support afterward. It is not a personality trait and should not be framed as a permanent pass or fail judgment. Depth can be confused with intensity. A session that produces extreme activation is not necessarily doing more useful processing. Effective work requires enough present orientation and dual attention for adaptive information to become available. The 5-domain map gives us alternatives to the binary choice of full processing or no processing. We can shift targets, adjust set length and speed, use more frequent return to present orientation, strengthen a resource, address a practical threat, or work in another domain. The decision should be followed by reevaluation. Did the client remain connected? What happened after the session? Did functioning improve, deteriorate, or remain stable? Education and understanding addresses a client's explanatory map. Trauma symptoms are often frightening because they feel random or morally revealing. Naming a flashback, trigger, avoidance, cycle, dissociative response, or conditioned alarm can turn an experience from I am losing control into my system is responding to a cue. Good psychoeducation normalizes without minimizing. It explains how a response may have been protective while acknowledging the current cost. It also supports informed consent by explaining what em-dir therapy involves, what bilateral stimulation cannot do, how targets are selected, and what alternatives are available. The explanation must fit the person's language, culture, education, spirituality, and preferences. Technical accuracy does not require technical vocabulary. This domain is successful when the explanation creates more choice, compassion, and collaboration, not when the client can repeat a lecture about the brain. A coherent explanation changes the relationship to symptoms. The client who says, I am weak because I froze, may begin to understand immobility as an automatic defensive response. The client who says, I chose this, may recognize coercion, grooming, attachment needs, or a survival calculation that was invisible at the time. The purpose is not to remove responsibility wherever responsibility exists. It is to replace global shame with a more accurate account of what happened, what was learned, and what can change now. Within em-dir therapy, this understanding can improve target selection. It may reveal feeder memories, blocking beliefs, present triggers, feared future templates, or identity conclusions that organize the problem. It also protects against procedural mystification. Clients should know why we are proposing a target or intervention and should be able to disagree, ask questions, or choose another route. AIP theory can offer a useful explanation when translated carefully. We can describe symptoms as present activation of learning stored in a way that has not fully integrated with adaptive information. A cue in the present activates the network, and the person responds as if the old danger, shame, helplessness, or responsibility remains current. That explanation should remain a clinical model, not be presented as a literal photograph of the brain. It should also be adapted to the client. Some clients prefer nervous system language, some relational language, some spiritual or moral language, and some simply want a practical account. AIP-informed psychoeducation can prepare clients for the movement of memory during processing and normalize unexpected associations. It can also explain why the earliest event is not always the best starting target and why present triggers or future templates may be clinically useful. The test is whether the explanation improves consent, curiosity, and choice. Skill development includes more than calming techniques. Skills can help the client orient to the present, recognize activation, reduce intensity, increase energy during shutdown, communicate needs, set boundaries, organize daily tasks, or recover after a difficult session. The domain is framed around choice. A skill is useful when it gives the client another possible response. It should not become a performance standard that must be mastered before the therapist is willing to proceed. Skills are also state-sensitive. Slow breathing may help one client and increase panic or air hunger in another. Closing the eyes may support concentration or intensify dissociation. Stillness may soothe one person while movement is necessary for another. The therapist and client therefore test skills empirically. What happened when we tried it? Did orientation improve? Did the client gain flexibility? If not, the method changes. Preparation should be individualized to the client's state and the anticipated demands of the work. When activation is high, the client may benefit from slower pacing, visual orientation, pressure, movement, a shorter target exposure, or more frequent contact with present safety. When the client is shut down, overly soothing strategies may deepen collapse. Upright posture, rhythm, movement, voice, temperature, or relational engagement may add usable energy. When dissociation is prominent, the priority may be sensory orientation, dual attention, time and place cues, and a shared plan for recognizing loss of contact. This is compatible with em-dir preparation phase, but the 5-domain model does not equate skill development with phase 2. Skill needs can reappear during assessment, processing, closure, or reevaluation. Preparation remains available throughout treatment. Preparation is most useful when it is tied to a specific anticipated need. Rather than asking whether the client has enough coping skills in the abstract, ask what could interrupt the plan work. Is the concern loss of orientation, rapid escalation, prolonged shutdown, inability to stop, shame about needing a pause, or poor recovery afterward? Then practice the relevant response while activation is manageable. Confirm that the client can use the stop signal, shift attention, reorient to the room, communicate a need, or contact support after the session. Avoid turning the resource development phase into endless rehearsal. Social connection recognizes that regulation and meaning are relational. The domain includes the therapeutic relationship, family, friends, peers, faith communities, cultural belonging, mutual aid, and professional supports. It also includes the ability to set limits and leave unsafe relationships. Trauma can make closeness feel dangerous and isolation feel protective. Some clients need help noticing trustworthy behavior. Others need support recognizing coercion, inconsistency, or exploitation. Within em-dir therapy, connection affects consent, pacing, willingness to disclose difficulty, ability to use a stop signal, and the client's capacity to remain in dual attention. The therapist's steadiness can support regulation, but the aim is not dependence. A strong social connection profile does not require many relationships. 1 or 2 reliable, respectful connections may be more protective than a large network that is invalidating or unsafe. Trust is rarely produced by reassurance alone. Clients learn relational safety through repeated evidence. The therapist explains what will happen, respects hesitation, responds to a stop signal, notices changes in contact, acknowledges mistakes, and repairs ruptures. This is especially important when trauma involved betrayal, coercion, grooming, institutional harm, or authority figures. A procedure that is technically correct can still reproduce helplessness if consent becomes assumed or the therapist pushes past the client's signals. Repair is not evidence that treatment failed. Misattunements are inevitable. The therapeutic relationship is sometimes discussed as a general factor surrounding em-dir technique. Clinically, it is also procedural. The client must be able to communicate changes in orientation, ask for a pause, reject an interweave, or report that the therapist's pacing is not working. The therapist needs enough attunement to detect when apparent compliance has replaced collaboration. This does not mean processing must remain comfortable. It means discomfort occurs within an ongoing structure of consent, dual attention, responsiveness, and choice. When a rupture occurs, repair may itself create adaptive information. Disagreement does not automatically lead to punishment. A boundary can be respected, and a relationship can survive honest feedback. The 5-domain map keeps social connection visible when the therapist might otherwise interpret every obstacle as a target memory problem. Meaning and memory work is the domain most visibly associated with trauma processing. It includes target memories, present triggers, future templates, and maladaptive conclusions about danger, responsibility, worth, power, trust, or identity. It also includes grief, moral injury, spiritual injury, narrative reconstruction, purpose, and integration. Not every problem in this domain is reducible to a single target. Some clients are organized around repeated developmental experiences, institutional betrayal, chronic coercion, or a moral conflict that requires mourning and change purpose as well as reprocessing. The goal is not erasure. The event remains part of autobiographical memory, but it becomes less present tense, less identity-defining, and less able to dictate current behavior. This domain often draws on the other four. Safety protects the work, understanding gives it context, skills support flexible attention, and connection reduces isolation. Trauma processing is often misunderstood as reliving the event at maximum intensity. em-dir processing requires enough activation to access the relevant network and enough present orientation for adaptive information to become available. The balance varies by client, target, and moment. When contact with the present narrows too far, the therapist may shorten sets, slow the pace, orient to the room, increase relational contact, use distancing, modify the target, or stop. Those choices are not necessarily avoidance. They may restore the conditions for productive processing. We also observe more than the SUD score. Are associations moving? Is responsibility changing? Is the client more connected to adult perspective, choice, compassion, grief, or protective action? What happens after the session? Processing is successful when the memory becomes more integrated and the person gains freedom, not when the session looks dramatic. The memory processing procedures of em-dir most directly serve meaning and memory work, but em-dir therapy is not confined to that domain. History taking and treatment planning may reveal crisis needs, explanatory gaps, skill needs, relational conditions, and memory targets. Preparation can serve skill development, social connection, and education and understanding. Closure and reevaluation monitor safety, functioning, integration, and current context. This is why it is inaccurate to describe em-dir as eye movements or bilateral stimulation. It is a comprehensive 8-phase psychotherapy organized by AIP theory. The 5-domain model offers an orthogonal view. It asks what area of need the current intervention is serving. An em-dir procedure can support more than one domain, and another evidence-based or practical intervention may be the best fit for a particular domain at a particular time. The map supports integration rather than brand competition. Meaning and memory work must remain broad enough for wounds that are not primarily organized around fear. Moral injury may involve perpetration, omission, betrayal, or witnessing events that violate deeply held values. Spiritual injury may involve coercive religious authority, loss of faith, shame, or rupture with a community. em-dir targets can address sensory memories, responsibility, guilt, shame, betrayal, and identity conclusions. Yet reprocessing may not be the entire task. Some clients need grief, restitution where possible, accountability, forgiveness, renewed values, or a changed form of purpose. The therapist should avoid imposing a theological or moral resolution. The client's worldview remains central. Integration means the event becomes connected with time, context, responsibility, and the rest of life. It can be remembered without becoming the whole identity. The 5-domain model and em-dir 8 phases should not be collapsed into one another. The 5 domains describe areas of need. The 8 phases describe the workflow of em-dir therapy, history taking and treatment planning, preparation, assessment, desensitization, installation, body scan, closure, and reevaluation. Any phase can involve attention to several domains. During phase 1, we may identify crisis, educational, skill, relational, and memory needs. During processing phases, we continue to monitor safety, orientation, consent, and connection. During reevaluation, we assess more than target disturbance. We examine functioning and the wider domain profile. Similarly, meaning and memory work is larger than phases 3 through 7. It may include grief, identity, values, and integration that occur across the course of treatment. Keeping the maps distinct prevents the domain model from becoming a disguised stage model. A global statement such as "not ready for em-dir" often obscures the actual concern. Readiness is specific to the person, target, procedure, dose, context, therapeutic relationship, and support available afterward. It can also change rapidly. The clinical task is to name the limiting variable. Is the client losing present orientation? Is the target too broad? Is the session too short for closure? Is the home environment unsafe? Is there a medical or substance-related concern? Does the client need a different explanation or stronger confidence that stopping will be respected? Once the variable is named, we have options. We can modify the intervention, address another domain, consult, coordinate care, or choose a different level of care. Specific language reduces shame and makes treatment planning testable. We can observe whether the change actually improves access and recovery. The domain-informed dosing loop makes the model operational. First, check the current profile. What is urgent, impaired, strengthening, or newly available across the 5 domains? Second, choose the clinical intention. Are we trying to increase safety, improve understanding, build a capacity, strengthen connection, or integrate memory and meaning? Third, select the target, procedure, and dose that fit that intention. This may be standard reprocessing, a modified protocol, preparation, psychoeducation, relational repair, practical planning, or another evidence-based intervention. Fourth, observe both the in-session response and recovery afterward. Track orientation, activation, associations, functioning, relationship, and what became more or less possible. Finally, remap. If the profile changed, the treatment focus can change without labeling the shift as resistance or failure. Return to the opening case. Crisis stabilization includes severe sleep loss and an emotionally coercive relationship. We need more information about immediate danger, escalation, substance use, medical factors, and the client's options. Education and understanding is partly strong. The client understands PTSD. It is also narrow because the client equates authentic em-dir with immediate reprocessing. Skill development is mixed. Grounding works during mild activation, but we do not yet know whether the client can remain oriented to this target or recover afterward. Social connection is limited by avoidance and possible coercive isolation. The therapeutic relationship may be carrying most of the regulation. Meaning and memory work contains a clear assault target and likely conclusions about danger, responsibility, power, or worth. The map does not tell us one mandatory answer. It shows what must be considered. The domain profile supports at least 2 defensible routes, depending on information we do not yet have. Route A prioritizes crisis stabilization and social connection, assess coercive danger, strengthen options, address sleep, identify support, and then reassess memory work. This route is especially strong if risk is escalating, sleep loss is severe, or the client cannot recover after activation. Route B begins carefully dosed meaning and memory work while continuing safety interventions. The therapist might choose a narrow target, shorter sets, frequent orientation, clear stop procedures, and a strong recovery plan. This may be reasonable if danger is not acute, the client retains dual attention, and processing is expected to reduce a symptom that is worsening the other domains. The point is not that every route is equally good. The point is that the rationale should be specific, collaborative, observable, and revisable. The model can be used as a brief check-in rather than a lengthy assessment. For a current case, ask, is the client safe enough and functioning well enough for the planned work? Do the client and therapist share a usable explanation of what is happening and why this intervention is being proposed? What skill, resource, boundary, or practical capacity would make the next step more workable? Who or what supports regulation and recovery inside and outside the session? What memory, meaning, identity, grief, or unfinished learning is asking for attention? The check-in can occur during planning, before a target, after a setback, or during reevaluation. It is not a score and does not need to produce 5 interventions. Its purpose is to identify the next most useful question. I will close with 3 points. First, the 5-domain model is a nonlinear case formulation map. It identifies areas of need without turning them into stages or prerequisites. Second, it complements rather than replaces AIP theory and em-dir 8 phases. The domains answer where help may be needed now. The phases describe how em-dir therapy is conducted. Third, readiness and dosing should be specific. We consider the person, target, procedure, dose, context, relationship, and support afterward. We intervene, observe, and remap. The model is intended to increase curiosity and collaboration. It is not yet a validated outcome instrument and should not be presented as one. Choose the domain that needs attention today. One next step is enough, and the map can change when the person's needs change.